Well, good evening, everyone, and welcome. Thank you so much for joining us for another Wellness Webinar Series event with Jefferson Health. My name is Sarah Breckbill, and I will be serving as your program facilitator and will present your questions to our panel of experts. Well, back and neck pain are all too common for many in the Philadelphia area. This webinar will feature Jefferson Health's leading spine and pain management specialists to discuss causes of back and neck pain and give insights into advanced new treatments, both surgical and non-surgical. We'll also discuss minimally invasive treatments, the latest technologies, including robotics and magnetic resonance imaging guided procedures, and other latest treatments from Philadelphia's leading spine center. Well, thank you so much for submitting your questions in advance of tonight. And the questions that you'll hear me asking the panelists are all submitted right from when you registered for this webinar. If you have any questions throughout our discussion tonight, for those joining us on your computer or tablet, at the bottom of your screen, you should see an icon that says Q&A. We'll do our very best to get to as many questions as possible, but may not be able to answer all of them during tonight's virtual event. And due to hospital, university guidelines and privacy, we are unable to comment on specific cases. Likewise, if you are experiencing any symptoms that may require immediate medical attention, please consult a medical professional. Finally, don't worry, we've taken the liberty of muting everyone's line to eliminate any background noise, so feel free to move around and get comfortable. So with that, I want to go ahead and introduce our experts for the evening, starting with Dr. Patrick Cooper with spine surgery and neurosurgery, Dr. Christopher Fico, physical medicine and rehabilitation and pain medicine, Dr. Jack Jallow, spine surgery and neurosurgery, and Dr. Richard Schmidt, neurosurgery, spine surgery, and endovascular neurosurgery. So let's go ahead and just have each one of you take a few minutes to share a bit of background information about yourself for the audience. So Dr. Cooper, we'll go ahead and start with you. How are you doing this evening?
I'm doing pretty good. Thank you so much. Good evening. My name is Patrick Cooper, and I work primarily out of Jefferson Einstein in North Philadelphia and Montgomery area. My background is in general neurosurgery with emphasis on neurosurgical oncology, but related to the fact I did a full career in the military dealing with a lot of neck and back issues. That is a prime focus that I continue with today.
Right. Well, thank you so much for joining us tonight. Now we'll turn to Dr. Christopher Fico. How are you doing tonight?
Well, thank you, Sarah. Yeah, pleased to be here. About me, I trained here at Jefferson and did my residency. I'm a Philadelphia local, and then I've done a few fellowships in brain injury medicine as well as pain medicine. The areas of my focus in my practice are general rehabilitation, but also trying to provide some novel techniques for pain management in people with disabilities.
All right. Well, thank you for joining us. Okay. And Dr. Jallow, how are you doing tonight?
I'm good, Sarah. Thanks for organizing the event tonight. In terms of myself, I'm been in Philadelphia since 1990, did my training in Philadelphia and have stayed on all these many years, going on decades now. My practice is almost exclusively spine surgery and pretty much any aspect of spine surgery.
All right. And thank you. And last but not least, Dr. Schmidt, how are you doing?
I'm doing great, Sarah. Thanks for inviting me on for tonight. So I have done all of my training with Jefferson. So I've been in Philadelphia for over a decade now. My practice is primarily out of Southern New Jersey. I run a very diverse practice, do a lot of general neurosurgery, take care of a lot of spinal conditions, but I am also fellowship trained in endovascular neurosurgery and vascular neurosurgery. So I see a lot of patients for stroke and other neurosurgical conditions of the brain in addition to the spine.
Okay. Well, thank you all for introducing yourself. And I know we have a big discussion ahead of us. So without further ado, let's get started with our first question of the evening. So Dr. Cooper, I'm going to turn it to you to kick us off. So the first question, What treatments are available for degenerative disc disease?
Okay, very good. So I'll start off by kind of defining some terms. The term degenerative disc disease refers to a degenerative condition of the spine. Now, the discs are essentially the cushions in between the vertebrae or the bones in your spine, and they allow for flexibility and cushioning and support of your spine. Over time, they can wear out due to various conditions, including just normal wear and tear or trauma. And on occasion, those degeneration can cause symptoms. A lot of times, degenerative disc disease is diagnosed during workup for neck or back-related pain or other issues. And it's not infrequent for people to get diagnosed with degenerative disc disease on imaging done for other reasons. So degenerative disc disease by itself is not a serious disease, but in certain circumstances, the degeneration can cause side effects that can lead to pain, including axial back pain. They can lead to side effects that result in irritation of the surrounding nerve roots that can cause extremity pain, so pain in the arms or legs. The general treatment for it is, and this will be a common theme throughout the evening, is initial trials of non-operative treatments. So initial evaluation and finding of degenerative disc disease thought related to back pain usually start with over-the-counter medications such as non-steroidal anti-inflammatories, some activity modification if need be, and then the treatments progress from there. Physical therapy is often used for most initial treatments of spine-related problems, and that focuses on strengthening the muscles around the spine to provide additional support, as well as providing increased flexibility. In circumstances where the degenerated disc is causing side effects, the next step is some sort of pain intervention procedures that can be targeted to treat the condition around where the disc degeneration is. And then kind of the last step is an operation of some sort, and that varies depending on the exact symptoms, the duration of the symptoms, any other medical problems that you may have. From the simplistic terms, it could mean anything from a small operation to try and clean up around a nerve that might be related to the degeneration of a disc, to an operation that would potentially help restore the disc height and immobilize that part of the spine that might be causing pain. And that procedure is some sort of spinal fusion procedure.
Okay. Well, thank you so much for taking the time to walk us through that. We really appreciate it. That was helpful to set us up for the first questions. We appreciate it. All right, so we will move along to our second question. I see that Dr. Fico may have dropped off. So let's turn to our third question, Dr. Jallo. For someone who has both knee and back issues, what do you recommend treating first? The knee or the back, and how does each issue affect one another? Oh, and I think you may be on mute.
Thank you.
Perfect.
I was. As you might imagine, it's all, knee pain causes you to limp, will aggravate your back symptoms. If you have back symptoms that are interfering with your ability to ambulate, that can impact your knee. If you have both, both knee pain and back pain often represent a deterioration or an aging wearing out of joints. Your back is just a series of joints, as Dr. Cooper is pointing out, with the discs between the bones. Your knee is a joint that allows you to move, and when they wear out, they hurt. If you have back pain and knee pain, I generally recommend starting with, I imagine what Dr. Fico would have commented on, was just physical therapy and strengthening, as Dr. Cooper mentioned. If that doesn't get better and pain management with injections or steroids don't help, then the next step ends up being trying to identify which is the primary source of functional limitation. So if you have a pinched nerve in your back that is impacting your ability to ambulate, and you have knee pain from a joint that's worn out, that nerve needs to activate the muscles that support the knee. And I'm generally a fan of addressing the spine first to make sure that the nerve that activates the muscles is free from any compression and allows you to build the muscle strength around the knee that you need to recover from your knee surgery.
Okay.
Long answer to a short question. Thank you.
Well, we appreciate it. So thank you. All right, moving along to our next question, Dr. Schmidt, this one is for you. Are there new advancements for treating cervical spine disorders?
Yes, I mean, in general, the management of spine disease, primarily because it's so common and is very technology driven. I think there's advancements happening every day across the board, whether it's in the cervical spine and the lumbar spine. And a lot of those advancements translate across the spine because we have similar types of approaches and way of addressing these problems. Some of this to highlight specifically in regards to what we typically do in terms of surgery. Now, the sort of what we call workhorse surgeries for addressing issues of the cervical spine generally is either an anterior or a posterior approach to the spine, doing some sort of decompression wherever the problem is, and then oftentimes some sort of fusion where we put some sort of instrumentation in there to sort of stabilize the bones. Now, as our understanding of spinal anatomy and technologies in approaching the spine and different ways of getting to the spine, certain things have developed. One that's becoming much more common is not necessarily a new technology, but I think its indications have expanded, and that is actually disc replacement. And what that is instead of removing a disc and fusing those levels, meaning putting plates and screws so that they don't move, we actually insert a artificial disc that functions biomechanically in the same way that a normal disc would. And in this way, you can maintain mobility at that level and prevent breakdown at the levels adjacent to that. Additionally, we have minimally invasive ways of approaching the spine. There are certain types of procedures that can be done to actually cause a fusion in the back, where we can put grafts into the facet joints in the back that can cause those levels to fuse together if that's the primary pain generator. And additionally, there is some research now being done on even endoscopic approaches to the cervical spine using a small scope. Now, obviously, this is a very nuanced area of treatment, and these discussions need to be had if people are considering surgery, of what the risks and benefits are of all of these approaches. As with any new technology, they have their place, but it is a discussion in regards to where that place is in regards to the more standard, like I said, sort of workhorse approaches to addressing these issues.
Okay, thank you. Really interesting to hear about the new advancements, especially minimally invasive options there as well. So thank you. All right, moving along to our next question, Dr. Cooper, this one is for you. Can you talk a little bit about surgical options for fixed pinched nerves in the neck and back, and are there non-surgical options?
Sure. I'll once again try and define a very big topic into a little area. When we think about a pinched nerve in the neck or the back, those can be caused by various different causes. They can be related to degeneration of the disc, like I talked about earlier. Those discs can have softer center parts of the disc that can move out of the center of the disc and irritate the nerve. If the disc collapses, it can narrow the hole where the nerves come off the spine at either the cervical, the top part of your neck or the bottom part of your back, and those can irritate nerves. A pinched nerve can be caused by other things, including rare cases of tumors or infections or other issues. So the primary goal of fixing symptoms related to a pinched nerve is to, number one, identify what's causing the pinching, because if you can't really see it, then you can't go in and fix it very easily. And that's where imaging of some sort comes into play. And when I say imaging, X-rays or CAT scan, or most commonly an MRI. Once a pinched nerve is identified, there can be various different options for treating it, but the primary treatments include decreasing the inflammation around the nerve initially, and those can be done oftentimes non-operatively, and ways to assist with that are rest and activity modification to avoid irritation of that nerve, taking over-the-counter non-steroidal anti-inflammatories, like I mentioned previously. And then you can escalate the care to doing pain management interventions, which oftentimes include injecting a numbing medication and a steroid around that nerve to assist with getting rid of the inflammation. If the symptoms persist, despite that, then the surgical options, the primary goal is to essentially take the pressure off that nerve. And the way the pressure is taken off that nerve depends on many factors. It depends on what the ultimate cause of that pressure is, whether it's a disc that's bulging out or a bone spur that's been created around a degenerated disc, whether it's narrowing around the hole where the nerve comes out, or whether it's a narrowing around the central part of the spine or spinal cord, will depend on what the surgical treatment is. So the term we use to get the pressure off is a decompression, and there's various ways of doing that. You can do a direct decompression, and that's taking away the bulging disc or the overgrown bone spur away from the nerve. Or you can do sometimes something called an indirect decompression, where if you reestablish the normal height of a disc, that will oftentimes allow you to open up the nerve hole, the hole where the nerve comes off the spine, sufficiently to relieve that pinched nerve. So what it boils down to is essentially getting pressure off the pinched nerve that's inflamed, only when that inflammation is present for a long enough amount of time that we know that it's not going to get better on its own or with non-operative treatment.
Okay. Well, thank you so much. And thank you for condensing that into a quick answer. So we appreciate you detailing that for us. All right. We will move along. Now, a question for you, Dr. Fico. Are Botox injections used for the neck pain, headaches, and back pain? And how effective are these injections? And how long do they last?
Sure, Sarah. That's a great question. So let me kind of back up a little bit and talk a little bit about Botox. And what's great about this is there's a growing list of indications and uses for it. So Botox is a toxin, and we use it as part of a procedure that we call chemodenervation. And what we're trying to do is trying to chemically affect how nerves behave. And the way that it works is when you inject this into a targeted area, as you mentioned, it can be in the head for headaches, or in the neck or the back. What we're trying to do is we're trying to change how neurotransmitters work. In this case, these are chemicals that our nerves release. So this medicine is taken up locally by those nerves, and then it changes the electrical and the chemical activity. And so when we inject it in an area where there's a lot of muscle, what it's going to do is it's going to affect a chemical called acetylcholine. And that's the main chemical that's responsible for how our muscles contract. So sometimes there's conditions where our muscles will contract inappropriately. And that, if you've ever had a muscle cramp or a spasm, you wake up in the middle of the night and your foot is cramping, and you have to stand up and make it feel better. Imagine if that were to continue for 5 minutes, 10 minutes, an hour. It would be very, very painful. So that could be a condition called spasticity, or maybe even something else called dystonia, where your muscles behave inappropriately. And doing that, can affect your movements, and can affect your, can cause a lot of pain. So that's probably where you would think about using Botox the most, to try to get those muscles to relax and to hopefully move better, move more normally, to allow the reestablishment of normal movement. So that's kind of speaking to the neck in the back. In the head, there's a little bit different protocol, and it's very well established. Botox has a long-standing indication for headache management, and the way that it's used there is it's used in prevention of migraine or migrainous headaches with migrainous features. In any of the cases that we talked about, using it for the neck, using it for the back, or using it for headache, we're typically allowed to inject it every 3 months. And what I mean by that is that's typically what insurance, those are the parameters that we're working under with insurance. Most patients will report very good relief if this works for them. Very good relief for usually about 6 to 8 weeks, and then usually over a period of 4 weeks preceding a scheduled injection, they may see some reduction in the efficacy of those injections. And just to kind of talk about it, if anyone is considering it, it's a procedure, but it's done in the office at the bedside. It typically will take 10 to 15 minutes, maybe 20 minutes at the most, and really risks associated with this are minimal. No worse than any time you stick a needle through skin. So bleeding, bruising, potentially infection, but with these procedures, you're using sterile equipment. So these are just theoretical risks. Another side effect just from the needles is sometimes there's some soreness, and most people would say that resolves with some icing and 15 minutes of icing a few times a day, and that takes care of that.
Okay, well, thank you so much for talking through that option there as well. All right, we will continue along with our next question. And this question is for you, Dr. Jallow. At what point should someone seek surgical options for a pinched spinal cord or spinal cord compression?
Very good question. And I think this is going to segue into Dr. Cooper's comments, if you don't mind. It was a really good background on that. And I just want to make a distinction between spinal cord compression versus spinal nerve compression. And spinal stenosis, which is a narrowing of the spinal canal, which is the space where the spinal cord sits. If you think of the spinal cord as the trunk of the tree, the spinal nerves are the branches that come off that tree. Pressure on those nerves is very amenable often to, one, just giving them time. Many nerve root compressions or spinal nerve compressions will improve over time as inflammation subsides. If they don't, then we pursue a course of physical therapy, start injections to reduce inflammation, and then if all else fails, we talk surgery. Spinal cord compression, on the other hand, is pressure on the trunk of that tree, which is the main cable that connects your brain to your body. And as soon as you have pressure on the spinal cord, I recommend seeking medical attention, especially if you have symptoms of spinal cord compression, such as cervical myelopathy. I think in the chat, someone had a question about cervical myelopathy, which is really the word that we use to describe the early symptoms of spinal cord compression. And that can include anything from clumsiness in the hands, dropping objects, difficulty with balance, a feeling like you can't quite control your bladder or your bowel as well. Now, lots of things can cause any of those symptoms. And in the absence of spinal cord compression, which we can really only identify on MRI images, but once you have pressure on an MRI matched with those symptoms, then we start thinking about how do we get pressure off the spinal cord. And then we talk into some of the issues that Dr. Schmidt mentioned in terms of novel technologies, both in terms of imaging, robotics. I think there's a question there about stem cells, but really that's really all experimental. The goal of surgery is really just to get pressure off the spinal cord. And the major advances in neurosurgery have been, especially with regards to spine surgery, is one, imaging. We have the most advanced imaging available in the world at Jefferson, and are at the forefront of both robotic and navigated spinal surgeries, in addition to sort of all the host of other technologies you might imagine. One last comment. There's a lot on the interwebs about the bone scalpel as a way to perform a decompression, and that is available to all of us. It's not anything that isn't available at Jefferson.
Okay,
I'll
thank
leave it
you
at
so
that.
much. And including that tree analogy, that was really helpful for painting that picture. So thank you. And I know that you mentioned a live question in the chat, so we will be getting to live questions in just a minute. So feel free to keep submitting those questions throughout our discussion. But for now, we will turn to our next question. Dr. Schmidt, question for you. What are next steps when therapy and back injections stop working?
All right, so we've, Dr. Cooper, Dr. Fico, and Dr. Jallo, we've all kind of been touching on this, that there is a stepwise approach when someone has, disease of the spine, whether it's in the cervical spine or the lumbar spine, which is the lower back, and whether it's affecting the spinal cord or the nerve roots. In general, surgery in terms of trying to do a decompression, as was mentioned before, which is the procedure of removing wherever that pressure is, whether it's on a nerve or the spinal cord, we typically reserve it as a last resort when all other therapies have failed. So really, when we talk about someone who's undergone a course of physical therapy, has not demonstrated any significant improvement, has proceeded with other non-operative interventions, whether it be injections, oral medications, even nerve root ablations in certain situations, things to try and control the pain or symptoms in other methods. When those fail, then, that's typically when the discussion would be had regarding the potential role of surgery. Now, what exactly that surgery would entail in terms of it being a decompression, again, focusing on moving the pressure where the issue is, incorporating something called a fusion, which would be where we put typically rods, titanium rods and screws or plates, various devices into the spine to stabilize the spine. As was discussed earlier, when we talk about the discs that are almost like a padding between the vertebral bodies that allow them to move, if certain processes progress where that movement is causing a problem, is actually worsening compression on the nerve roots or the spinal cord, and we need to stop that movement for whatever reason, or we need to stabilize the spine for whatever reason, that's when something like a fusion would come into play. But again, a lot of the specifics of what surgical intervention entails, and again, what sort of new technologies can be incorporated into that surgery, whether it's, as Dr. Jallo mentioned, robotics or things like disc replacement or less invasive approaches. A lot of that is very idiosyncratic or very specific to the specific problem going on with that patient. But again, those discussions enter the treatment into the treatment discussion once the physical therapy and the less invasive methods of treating the pain or whatever symptoms are going on have failed. And again, I like to always educate my patients on this, and the phrase I use is surgery is really only a good option when it's the last good option we have. And I think that's generally a good way to approach treatment of the spine.
Okay. Well, thank you for sharing that sentiment. A good reminder for us all there. Okay, Dr. Cooper, question for you. Can you tell whether a sacroiliac joint pain is an injury or arthritis, and is the treatment different?
So that's kind of a tough question. First First of all, differentiating sacroiliac pain is not always straightforward. To back up again and kind of define the terms, sacroiliac joint is essentially the connection between the lowermost bone in your spine, the sacrum, and your pelvis, part of the bone called the ilium. And that joint acts as a shock absorber, essentially relieving some of the stresses from your legs through your pelvis up into your spine. It's a joint like many other joints that can get degenerated from arthritis of various sorts. It can wear out over time and it can be injured. When we talk about injuries to the SI joint, they're usually related to some traumatic event, such as a motor vehicle accident. Less significant injury can be related to heavy lifting, usually accompanied by a twisting motion at the same time. And so the first step in differentiating an injury or arthritis in the SI joint is a thorough history and physical. If you've had a trauma, you've had an event where it came on abruptly after heavy lifting or frequent bending or twisting, that's a good chance that there may be some injury to the surrounding ligaments in that area. Now, the more common scenario is that it's a combination of both, a minor injury to an already degenerated joint. Additional ways to try and isolate whether it's the SI joint causing the pain or other part of your spine causing the pain is a little bit difficult as well. And I think somebody mentioned on the chat, how do you determine whether or not your pain is coming from any number of degenerated discs in your spine? And the same applies to your SI joint. SI joint pain can often cause pain below the level of your lumbar 5 vertebrae, but similar symptoms can occur whether it's the SI joint or whether it's some of the other joints in the lower part of your spine, or even irritation of the lower lumbar nerve roots, specifically the L5 nerve root. Physical exam findings that we do can often help guide us and help narrow down whether those symptoms are coming from your SI joint. And those are various what we call provocative maneuvers. And there are several physical exam tests that we do that essentially stress that joint. And if it reproduces your pain, then it's likely that some of those symptoms are coming from your SI joint. Common theme again, the initial treatment for both injury and irritation from arthritis is non-operative to start and includes non-steroidal anti-inflammatories, physical therapy to strengthen, the lower muscles. Injections into the SI joint can help kind of confirm that the pain is actually causing from the SI joint. One injection is pretty good, and if you have 2 injections that confirm it both times, then you have a high likelihood that it's that joint that's causing your symptoms. Non-operative treatment, once you've determined that the SI joint is the cause of pain, can include additional injections or even what we call radio frequency ablation of some of the little nerves that transmit pain fibers from that area. And then in extreme cases where the pain persists or recurs over and over, there's procedures that can actually, just like in other parts of the spine, take away the motion or fuse that part of your spine with the thought that taking away that motion will take away some of the source of the pain. But that's generally thought of as the very last step. I didn't mention it earlier, but obviously if there, or maybe not obviously, but if there's a significant trauma such as a fall or direct injury to the lower spine, that would be something that would be diagnosed with x-rays to rule out a fracture in that area. And then the other typical diagnoses that we need to help make that is an MRI most of the time.
Okay, well, thank you. And as a follow-up question, you're not done yet here. Are there certain spine conditions you don't recommend surgery for?
So another great question. I would never say absolutely not, because that's a very broad topic. But in general terms, diffuse pain in the back without a clear cause of the pain would be something that I would not recommend surgery for. And it's as mentioned in the chat a few times, it's very common to have a diagnosis of multiple bulging discs or degenerative disc disease or arthritis in the back. And unless we can pinpoint where your pain is coming from, an operation should probably not be undertaken. There's other conditions in the back that are noted oftentimes on MRI reports, terms like small cysts in the lower part of your sacrum called Tarlov cysts. Those are rarely things that need an operation. And oftentimes, in my opinion, some narrowing around the spinal nerves and spinal canal related to something that we call epidural lipomatosis. And that's a big term for adipose tissue or fat tissue that tends to cushion that area. If it's pronounced, it can narrow those canals. In my opinion, surgery to take care of that is not a good option.
Okay. Well, thank you so much. We appreciate you walking us through that there. We will have one more question here before we dive into our live questions from the audience. So Dr. Fico, I will turn to you. Are there non-invasive ways to slow down the inevitable progression of moderate S-curve scoliosis into arthritis and pain?
Sure, that's a great question too. I like it. Maybe sound a little biased, the inevitable progression. But so yeah, let me kind of back up and talk a little bit about that. So scoliosis comes in many forms, and a lot of flavors. At the basic level, we would say it's a curvature of the spine, and that curvature can present in a lot of different ways. I mean, sometimes you notice this sort of, we call it an S curve, where it kind of curves one way in one portion of the spine and curves in another direction in another part of the spine. And most of the time, I would say, the causes of it are idiopathic. Meaning we don't really know why it happens, but there are other conditions where I think it could be, I guess you'd say, acquired, and the causes there would be things like potentially trauma to the back, things that could lead to accelerated degeneration of the spine. Also, I see this a lot in some neuromuscular conditions where we have muscle imbalances that are also responsible for maintaining our posture, and we can see people develop curves due to weakness of those muscles. In terms of progression, I guess I'd say, there's periods where I think we worry more about it than other periods. And so what I would say there is typically when we're going through periods of our most growth, maximal growth, in our teenage years and into our early adulthood is probably where we're going to see, I would call it a highest risk period where we may, worry about progression of the curve. And so I would say that the approach to take with this is to really get connected with a specialist where you can have a good set of eyes on this, so you can be examined. They can take measurements of the back and be able to watch what's happening with this curve. So there's a lot of very advanced imaging that can be done, and those images can be done, over time to really determine what's happening. In terms of trying to prevent a curve, I would say, really, what I would recommend as a rehab doctor is if you have a curvature but you don't really have much in the way of symptoms from it, then I would really encourage maximal activity and looking at trying to strengthen the back and to maintain movement as much as possible. There are some therapies that have shown pretty good evidence for improving posture and potentially even slowing some of the rates of change of those curves. So that is a possibility. I would say if therapy efforts did fail, then the other option I think that we would undertake or consider would be looking at bracing. And so what we're talking about there is applying something externally to the thorax, or I should say across the area where we know that there is a curve that's changing. And I think the considerations that we have to have there is really how quickly is it changing? How much more do we expect it to change? So, and part of that consideration is their age and also the cause of that curvature. And then what we'll do is we'll look at those measurements. One of the measurements is something that says, this is a simple measurement, it's on an X-ray called a Cobb angle, but our neurosurgical colleagues do a lot of other imaging to really look at the spine in 3D almost. And so if it got past a certain threshold, there probably would be a decision to consider bracing and then to observe after bracing and to see if there is continued progression. Unfortunately, if there would be, then we'd have to have a discussion, potentially about surgery. But I think in many cases of scoliosis, it's something that many people live with and live quite well with, and can be very, very active as long as they work on trying to maintain an active lifestyle and good core strength.
Okay. Well, thank you so much. And interesting to hear some of those therapies can have such a big impact too. So thanks there. Okay, so I know that we're going to be turning to our live questions. So Dr. Fico, I might actually start this first question off with you from our audience. I know that you just had a question here, but this is related to pain, so I think this might be a good one to kick us off with. What are new advancements for treating neck pain or back pain, especially non-addictive ones?
Sure. So I'm going to take the question to really, they're kind of probably leaning towards non-medical treatments for it, so non-medication related treatment. And I would say the area where we've probably started to do the most work in terms of trying to improve pain there would be using some new parameters for treating arthritis in the neck. And so many times, if there's arthritis in the neck, it can lead to changes in those joints. And what we're typically listening for in people who may have that is there pain contained within the neck? Also looking to make sure that there's no evidence that there's radiation of that pain into the shoulder or upper limb. So that would probably tell us that there's a different process going on. And so one of the things that we can look at doing is trying to do something called a radiofrequency ablation procedure. And what that is that's a procedure where we use a small needle that is actually a thermal probe, and we can deliver energy that creates heat. And what that then allows us to do is to alter the properties of the nerves that innervate those joints. And in doing so, we can hopefully stop some of that pain information from traveling up into the body, into the spinal cord, and going into the brain. Another area that I think is really promising, we're seeing a lot of growth almost every year, is using a procedure that we would kind of a catch-all term, but it's called neuromodulation. And what this is a way that we would do a procedure that involves putting an electrode into the epidural space, either in the cervical spine or the thoracic spine. So typically, putting it in the cervical spine can be used to treat neck pain and upper limb pain. And then inserting it into the thoracic spine can be used to treat back pain as well as lower limb pain. The reason I'm a big proponent of those procedures is that there is some qualifications that we have to do. So Dr. Cooper talked a little bit before when we were talking about SI joint pain about doing a diagnostic injection and trying to figure out if the sacroiliac pain is really the pain generator. And I agree with them because it takes a lot of work sometimes to figure out if the SI joint is causing pain. With this procedure, the neuromodulation procedure, we usually do what's called a trial. And in doing that trial, we implant percutaneously, so through the skin, an electrode that is then left in place for a period of as little as 3 days, but typically 5 to 7 days. And what it allows us to do is to adjust some of the parameters and to allow the patient to really experience if that is going to be an effective therapy for them. And then we meet again at the end of the trial and discuss, well, how was it for you? And I really tend to look at that as a very open-ended question. I want the patient to tell me, okay, sure, was there pain improved? But what I'm usually actually listening for is, how did it affect your quality of life? How did it affect your function? Were you able to do things in a different way, in a less cumbersome way, in a less restrictive way during the trial period? And I would say, every year there's new programming that's happening. There's new parameters that these devices are able to be set with. The batteries, which is called a pulse generator, are able to work longer. So there's a lot of advantages and changes that are happening to these devices that I think really are improving their usefulness and their applicability to pain in those areas.
Okay. Well, thank you so much. We appreciate it. We will go ahead now to our next live question. All right. So for our next question, how are robots used in spine surgery? Is it better? And are there risks? And Dr. Jallow, I will turn to you for this one, if you're up for it.
Sure. Thank you. Robots are really very new in spine surgery. They're mainly used to place the hardware that's required to stabilize the spine if you need to do a fusion. So the robot is used to both localize, the position of the portion of the spine that you want to fix with a pin or a rod, and then actually under supervision, we'll place that pin in the bone where it needs to be in order to allow for stabilization. I think in terms of advances, robotics is just one small aspect of it. I think it really ties into the new imaging that's available to us in surgery, as well as spinal navigation. It's really those three things together that have advanced the field of neurosurgery. I mean, I can see in a generation or so where robots may be doing the whole surgery themselves, but at this point, they're really performing one small step of the surgery. And they're mainly required when a decompression, as Dr. Schmidt and Cooper mentioned earlier, if a decompression is required to get pressure off a nerve or a spinal cord, depending on how much, when you say decompression, you're removing bone, disc, and ligament. And you can remove a small amount that is enough to get pressure off the nerve and not destabilize the spine. But in very advanced degenerative conditions, the amount of bone, joint tissue, and ligaments that needs to be removed is such that then the spine needs stabilization. When we talk stabilization, we're talking pins and rods. Historically, we just relied on the surgeon's skill and knowledge of anatomy to place the screw, in addition to standard X-rays. Now we have intraoperative CT scanners, in addition to navigation, which is like having a GPS system for your car to tell you where the car is going. The navigation in surgery tells you where the screw or the rod should go. And now we have the robot layered on top of that can facilitate screw or pin and rod placement.
Well, thank you. And very exciting to hear about some of these advancements. So interesting to hear, certainly. All right, let's turn to our next live question. Dr. Schmidt, I will turn to you for this one. What are the symptoms and causes of sciatica, and what are the treatments when there is pain? And I think you're on mute.
Yep,
Yep,
got
there you
it. So sciatica is a common phrase that people use typically to describe pain in the leg. The sciatic nerve is a very large nerve that kind of runs down the back of the leg, more or less, and supplies a lot of sensation along the back and the side of the leg. And so frequently people report sciatica when they get shooting pain in that region, usually the back and or the side of the leg. Now, the sciatic nerve itself, and I want to kind of put a caveat here that sciatica sometimes can be a bit of a misnomer, meaning an incorrect naming, where it's typically attributed to that nerve, but sometimes that experience of pain in that location is not actually coming from the nerve itself, but rather from the nerve roots in the spine. And there's several nerves in the spine that, your L2, L3, L4, L5, S1 nerve roots, essentially your entire lower spine, all of those nerves go to various areas and supply sensation in different spots of your leg. And I think this does, we've been kind of looking at some of the Q&A as well. There's a patient who had asked about the different distributions, if there's a way to tell where this pain has come from. In some ways, based on where that pain is exactly, we can narrow it down to a level or two or some specific areas of the spine. Now, we typically do confirmatory testing like imaging, sometimes an EMG, to sort of see if everything lines up, if where the pain is matches up to where there's compression on an MRI, and that matches up to where there might be abnormal findings on an EMG. And that might help us localize where that problem is. But several of those locations can give that sensation of pain that shoots down the leg, which a lot of people would term sciatica. And, we use that term interchangeably as well, but it's sort of a catch-all phrase used to describe what in essence is something we in medicine call radiculopathy, which radiculopathy is pain from the nerve roots. That's essentially what that translates to. And in that regard, we typically localize it to a compressed nerve in the spine. And when we talk about management of that, we, again, are going back to what we've been discussing about previously, where we start with simple over-the-counter medications, basic stretching, basic exercises, then progress to, more aggressive type therapies, things like physical therapy, and then non-operative interventions with things such as injections, ablations, and then ultimately, if all other methods fail, talk about surgery. But just to note on that sciatica, usually, oftentimes it's coming from degenerative disease and compression in the spine, but there are occasions as well when it can be coming from the nerve itself. Sometimes there's various entrapment syndromes. It can get stuck in a muscle or ligaments, or get inflamed. There's other processes that can cause irritation of that nerve itself. But most often when people refer to sciatica, it's referring to actually compression of the nerve roots in the spine causing that leg pain.
Okay. Well, thank you so much for walking us through that. We appreciate it. All right. We have one final question for our live questions, and then we will wrap it up as we're just nearing the hour. But for our last question, Dr. Cooper, I will turn it to you. This question from the audience member: I have been diagnosed with spinal stenosis. What are the treatment options? And what should I try before surgery? And how do I know if I need surgery?
Great question. A very common issue with lots of us as we get older, and sometimes not so old. As is kind of the theme of the evening, initial treatments include over-the-counter pain medications, non-steroidal anti-inflammatories if you're able to. Physical therapy is an excellent first start to help optimize your muscles around your spine. Spinal stenosis often is associated with, leg pain symptoms that get worse with ambulation and oftentimes get better very quickly when stopping ambulating. Injections can help a lot of people for various amounts of time, and those injections are hard to predict how long they're going to help and to what level. And then depending on many factors, if all of that persists and your symptoms are there and severe, then an operation to relieve the pressure around that part of your spine might be indicated. And whether that's also accompanied by the metal screws and rods to fuse that part of your spine depends on a lot of other factors. There's lots of things you can try before you have to think about doing an operation. I would say the thing that would push you to doing an operation sooner rather than waiting, it would be neurologic deficits, meaning weakness in the legs would be something that you wouldn't want to wait a really long time before addressing the problem of the pressure on those nerves.
Okay. All right. Well, thank you all. We have one last question, and that is a question from myself. So for the final question this evening, I would like to know, what are your goals for everyone listening in on this webinar? What would you like our viewers to take away from tonight? So Dr. Cooper, I will go ahead and start with you as we finish out our evening.
I had a lot to say. I'll try and keep it very quick. I want to acknowledge that neck and back pain can cause significant disability, and it can be extraordinarily frustrating. And it is not a condition that always has the easiest route to fix. And when we think about, quote unquote, fixing a back issue, a lot of times the goal is to just optimize your function and decrease the amount of pain and disability that you're having. But until we come up with better solutions, reversing time and the fountain of youth, a lot of these issues are a part of life and getting older, but there are very good solutions to help dealing with those conditions.
Okay. Well, thank you. Dr. Fico, we'll turn to you. Any last remarks and insights that you would like viewers to take away from tonight?
Well, yeah, I want to say thank you. I want to say thank you to my colleagues. I actually learned a lot tonight listening to you guys, so thank you for that. I would say something similar to Dr. Cooper. I say this a lot to my patients. I say, we need to build a better back. And I think that's we have to wait for us to evolve to get to have better backs. But I would say to everyone attending this that you're not alone, and I would say to you that you're already taking a good step attending this program. You obviously want to educate yourselves and to try to be proactive with your care, and I think that's really important. One of the things that I hear that again, to echo what Dr. Cooper just said is, when someone comes in and tells me they've been having this pain for 5 years or 10 years, and I kind of sometimes think to myself, well, why now? And I wish we could, turn back time and kind of start this process and try to take this proactive approach even earlier in this process. And I think in doing that, there is that possibility, as I was answering the question, to try to maybe prevent some of the sequelae of these, what are oftentimes degenerative conditions. So really, I'll leave you with that. I would just say there are a lot of treatment options available, and I think that if you choose to come to Jefferson, you have a great team of doctors who really want to try to help you and to try to improve your quality of life.
Okay. Well, thank you so much. All right, Dr. Jallow, we'll turn to you. Any last remarks?
to reinforce some of what's already been said, first of all, thank you all for joining us today. I think it's important, as a spine surgeon, we make a big distinction between axial pain or pain along the spine, whether it's neck, upper back, and low back, versus pain, numbness, weakness that goes into your arms and legs. Back pain, whether it's your neck, upper back, or low back, is often non-operative. Unless you have an infection, a tumor, something broken, those are rarely conditions where back or spine pain does well with surgery. Where we do phenomenally well with surgery is if you have a pinched nerve or a pinched spinal cord and you have symptoms in your arms or legs where it's compromising your function above and beyond spine pain. Symptoms that are involving the nerves that go out from the spine into your body. Those are the conditions that we do a really good job at fixing. People who can't walk can walk again. People who can't function independently and use their hands the way they're used to, getting pressure off the nerves that come off the spinal cord really improves people's ability to function in the world.
Okay. Well, thank you. And last but not least, Dr. Schmidt, any last remarks before we close out this evening?
I want to highlight something we've kind of been talking on at several points throughout the session. First off, yes, and thank you and everyone who attended. And also highlight something Dr. Fico said, when the overall theme of the evening, as you can tell, is that this is a multidisciplinary problem. This is a problem that takes a lot of different practitioners at a lot of different levels and a lot of different fields to really tackle in the most effective way. And to Dr. Fico's point, the sooner that you look out for care and to get this taken care of, the sooner everyone can get involved to try and help make you better in the best possible way. And one of the things I think we do very well at Jefferson is this multidisciplinary approach, and getting in to see a neurosurgeon early. I see a lot of patients and they're scared that they're talking to me. That doesn't mean you're getting surgery. This is a multidisciplinary approach. It's getting everyone on board early: pain management, physical therapy, physiatry, to try and tackle this problem in the most appropriate way. And that if things do need to get escalated or de-escalated, you're already on board with the right people who can take care of you in the most holistic, best possible manner. And I think that's really the best approach when it comes to taking care of someone's spine.
Absolutely. Well, thank you so much, all. I know I learned a lot. So I know Dr. Cooper, Fico, Dr. Jallo, and Dr. Schmidt, we really appreciate your time this evening. A lot of great information was shared about back and neck pain and treatment options. And thank you all for attending and submitting your questions. We will be posting an event survey, so you can let us know your thoughts. Was this helpful? Are there any other specialties you would like to hear from? Your feedback will bring more virtual events like this to you, the patients. If you would like someone to contact you directly to schedule an appointment with a Jefferson Health provider, please fill out the last question in the event survey. Be sure to visit jeffersonhealth.org to stay up to date on upcoming classes, events, and webinars just like this one. We have one last wellness webinar series before our summer break. On Tuesday, June 27th from 7 p.m. to 8 p.m., we will have a webinar discussing pelvic floor disorders and incontinence. You can register at jeffersonhealth.org/wellness webinar. And a recording of this event will be sent to you so you can rewatch at your convenience. And if you'd like to view other wellness webinar series events, please visit our Jefferson Health YouTube channel. We have everything from back and neck pain to robotic surgery to planning for pregnancy and much more. If there is anything anyone here at Jefferson can do for you in this time of need, please reach out to us. Thank you once again for joining, and please be sure to stay safe and healthy. Have a great night.